like to thank Parkinson Canada for having me to kick off this year's presentations. As Stan has introduced me, and my topic, which is the motivation and Parkinson's disease, especially apathy and impulsivity. This is what I'm hoping to talk to today. So I don't have any particular disclosures as part of this talk, other than having an honorarium from Parkinson Canada for this talk. I thought I would also introduce a warning to my presentation. It is very important that you realize that this presentation is content-driven. I will talk about a variety of treatments, including medications, and that you do not make any medication changes or adjustments without direct instructions from one of your treating physicians. I will talk about apathy and impulsivity in general terms, but how they apply to your specific situation has to be discussed with your treating physicians. So this is a very important point. The learning objectives that I hope to achieve at the end of this presentation will be to have you appreciate that apathy is one of a series of neuropsychiatric symptoms in Parkinson's disease, identify some of the contributing factors that may play a role in apathy, and also become familiar with some of the benefits and risks of strategies that can be used to address apathy. So, to begin with, Parkinson's disease. Parkinson's disease, as you all know, is a motor illness. This is what are the first symptoms that often people present with to see their neurologist. Their hand or their leg is not moving as well as it should be. However, other than a motor illness, it also has a variety of other, what I call the neuropsychiatric symptoms. These can include mood, such as depression, anxiety, or nervousness. Parkinson's disease can also cause cognitive difficulties, such as dementia. It can induce psychosis, so a loss of a sense of what's real, such as visual hallucinations or paranoia. There's autonomic symptoms such as constipation, lightheadedness with blood pressure changes, sexual dysfunctions, motivation difficulties, which we will be discussing at some length today. Pain is a factor with Parkinson's disease for some people, fatigue, sleep difficulties. So there's a whole constellation of symptoms that may be present along with this illness. And initially, it is this motor element, this movement element that's primary. However, as the illness goes on, you may sometimes see that it is these other neuropsychiatric symptoms that gain a prominence. In the treatment of Parkinson's disease, there is a mainstay of levodopa, carbidopa, the picture over on the right of the screen. There are also enzyme inhibitors, and dopamine agonists. Now, the dopamine agonists are medications that I will mention at some length during the course of this presentation. These are the ropinirole, pramipexole. There is a patch, the rotigotine patch, and a new medication called apomorphine in this subcategory of medications. And then there are some other ones and surgery as well as duodopa. So there's a whole group of various medications that are used. Now, this is probably one of the more important slides in my presentation. When you see a neurologist, what they are primarily treating is the motor aspect of your illness. So the blue loop, as I call it at the top of the slide, is a loop of movement. If there is not enough levodopa, there is akinesia, so lack of movement. If there is too much dopamine, there's dyskinesia. So this is the abnormal movements of not being able to sit still. And what a neurologist is trying to do is find a balance in which movement is virtually normal. However, there are other loops that are also at play and are also dopamine responsive. There is this associative loop, which is the green loop. There is, with low dopamine, impaired reward-associated learning. So when you are expecting yourself to feel good because you did something well, let's say you did 10,000 steps today, and you should expect yourself to feel really good because it's the first time you did 10,000 steps. If your dopamine is too low, you may actually not get that positive kick out of doing that. On the other hand, if dopamine is too high, you may have impaired failure-associated learning. So this is learning from negative consequences. Let's say you went to a casino and you spent $1,000 and you blew it all, and it's like all the money you have for the month, and you're not going to have money to pay rent. You would expect yourself to have a very negative response to that. If your dopamine is too high, you may actually not have it as strongly as you should. Then there's also the red loop, which is the limbic or emotional loop. When dopamine is too low, there may be more depressive symptoms or apathy. And when it's too high, you're hyper. Attention span is scattered. You may be euphoric, almost manic and impulsive. So these are the three major loops that the medications and dopamine are balancing. And they may not all be at the same spot. So for instance, to optimize your motor function may take a certain amount of dopamine, but what it would do is super optimize your emotion motivation circuit. So in that case, your motor function is okay, but all of a sudden you're hyper, your attention span is scattered, your emotions are too euphoric for the situation. This is all within the realm of dopamine, especially some of the medications like dopamine agonists that we will touch upon a little bit more as the presentation proceeds. Now, as already mentioned, with that introduction, I will go into the motivation and apathy. And perhaps the best way of capturing apathy is to take a transcript from some research we did with a group in Germany over a decade ago. This is an actual partner and an interviewer. P is for partner, I is for interviewer. And the partner says, how should I say this? He is very lazy, no energy at all, nothing. The interviewer, he doesn't help with the housework? No, not at all. Really? I go to work in the mornings, and when I get home, I have to do all the housework. No hovering, no dusting, nothing, yes? He gets up after me in the mornings, but he doesn't open the blinds or set the table, nothing. Although these are only small chores. And when you ask him about this, is he then at all reasonable? Well, yes. Then I hear, I have to change something, but nothing happens and he doesn't change anything. I say, strictly speaking, if I wouldn't swallow everything, then we would get into a fight every day, and that just would not be a life worth living anymore. This is something to do with apathy, something to do with a lack of participation. Apathy, it's important to realize, is not laziness. People with Parkinson's disease are by and large not lazy. Apathy is a behavioral syndrome, and I emphasize behavioral because behavior can be determined in a variety of different ways. Apathy is something that's often observed, and it's a syndrome of decreased self-initiated goal-oriented activity. It's common. At the time of presentation to a neurologist for the first time to diagnose Parkinson's disease, about a quarter to a third of people have some apathy. This normalizes as their Parkinson's gets treated. However, 5 to 10 years of illness can result in 40% or almost half people without dementia, without cognitive difficulties, having some apathy, or 60% with some cognitive difficulties. And we will touch upon that. It also increases with age. So this is something that's not just Parkinson's related. It actually, as we get older, we are more likely to be apathetic. Some of the contributing factors to apathy, and I have a reference at the bottom in case you're interested in reading more about this and the different brain areas that are involved, are reward deficiency syndrome, depression, executive dysfunction or a cognitive difficulty, decreased self-activation, energy conservation, and fear of doing something wrong. I will take these one by one into a little more detail to give you an idea of what I mean. So a reward deficiency syndrome is an emotional blunting or absence of emotional resonance, preventing the attachment of motivational values and pleasure to internal and external stimuli. This is very similar to, in depression, is called anhedonia, which means a lack of pleasure. Things just don't feel good. You may do things, you may walk your 10,000 steps, you may shovel the driveway of snow. We have a lot of snow here in Toronto, and yet there's no sense of accomplishment. Why do it? And that's apathy. Interestingly, antidepressants can have apathy as a side effect. It's a relatively rare side effect, but possible. Depression. Now, depression and apathy overlap. Depression is a sadness. That's one kind of depression, which is the typical one that we normally think of, somebody crying quite a bit, being sad, moping a lot. But there's this other part of depression, which is this anhedonic, this word I just mentioned, which is the lack of enjoyment, depression. But with depression, there's often this sensation of wrong, things not feeling good. There's an insight to it. Whereas with apathy, not so much. There's also in depression guilt, often negative thoughts about yourself, about the world. Things are seen with a very half-empty kind of look. There's a helplessness, hopelessness, pessimism, self-criticism, anxiety, and sometimes even suicidal thoughts. With apathy, there's decreased initiative, decreased participation, decreased interest in new things, interest in the world. There's just less drive altogether, but there's not the same sense of pessimism, of guilt, of shame. But there's also an overlap between these two. With apathy and depression, people are more likely to think a little bit slower, move slower, be less active, and certainly less enthusiastic. It's important to ask questions to figure out what it is, because the slide reminds me that people with Parkinson sometimes appear the same, whether they're very happy, very sad, very angry. The face does not show the emotion, and the face of someone who's apathetic and depressed can look very similar. Another part of apathy is executive dysfunction or cognitive dysfunction. Executive dysfunction is the most common form of cognitive difficulties people have with Parkinson's disease, and it affects action planning and organization. This is one quick way of capturing what executive dysfunction is. But it's also difficulty in redirecting attention to something that's new. So people get stuck in what I have here as cognitive inertia. What you do well, but switching to something else, problem solving, it's much more difficult than it would have been before Parkinson's disease. It results in decreased curiosity, much more rigidity, trouble sequencing complex tasks. So for instance, if you have to cook something, even something familiar, going from A to B to C to D to E on a recipe becomes more difficult. And also, it becomes much more difficult to determine how to start an activity. And activities become much more anxiety-provoking and much more overwhelming because of the difficulty of thinking through the activity and sequencing it and initiating it. Then there's also the auto-activation dysfunction, which is a lack of self-initiated thoughts and behaviors. It's sort of like a mental emptiness. Nothing to say, nothing seems to matter. The difference of this from the decreased reward is that people with auto-activation difficulties respond to external stimulation. And this can be very problematic for partners, because if you sit there at home and you say very little, the house seems really quiet, very little contribution, and then all of a sudden somebody knocks on the door and say, hey, is Bob there? And all of a sudden, boom, Bob's awake. Bob's like, hello, how are you? It's so nice to see you, comes to life. So the external stimulation of something novel, something new, seems to activate somebody who has this auto-activation difficulty. Now, there are these other two things that I mentioned when I listed the relevant factors to apathy. One of them is energy conservation. This is something I hear about quite a bit with Parkinson's disease. And it has to do with conserving energy because, you only have energy for a very limited number of things during the day. And they seem to just tire you out. So sitting there, conserving energy until there is enough energy and enough commitment to do the one thing. So being very selective in choosing the activity to pursue. The other one is, sometimes I hear about, it's a little bit like anxiety and a little bit about this executive dysfunction, but it's not wanting to be more of a burden, not wanting to be more of to screw up more. So getting into trouble because not using a walker. So I might just well sit here because every time I seem to get up, I get into trouble. I don't want to get up because I don't want to use the walker. It's only 3 steps, but I don't want to get into trouble. I don't want to fall. So I might as well just sit here. Kind of that kind of a mentality. Now, some of the management strategies I'm going to get into. The first list I am going to present is, I called it staying motivated because it actually precedes any apathy. It actually applies to anybody who's retired. And the reason I'm including it is that retirement is actually a challenge. And a lot of people with Parkinson's disease are retired. And staying motivated, staying involved is a huge issue. And it's actually a lot of work, except you don't get paid for it. So some of the things that I've put on my list, I got from the retirementtipsandtricks.com website that's listed at the bottom. So some of the things that I recommended, and I would recommend a daily routine. Work, get up at 7, have your breakfast, have your coffee, 9 o'clock, you read the newspaper, 10 o'clock, you go for a walk. Establish a routine. It doesn't mean every day has to be the same, but you want to have a routine, like a schedule. Set concrete goals. I want to walk 5,000 steps every day. Awesome. That's a goal. Find a hobby or a passion. Ideally, yes, this is what you want to have. Find an involvement. Find a connection in that way. Try and exercise daily. Be curious. Read something. Learn something. Socially active. Call up your friends. Call up your relatives. Do this regularly. Again, if this could be part of a routine that you call up Bob or have a coffee over Zoom with him on Tuesdays at 11, awesome. This is what you want to be able to do. Volunteer or get a part-time job for sure if you're able to. Start a retirement diary. Again, write things down. It's very motivational to see what you have done. And let go of old grudges and prejudices. One of the reasons I put this one in, or I included this one, is that sometimes we don't think of ourselves as joiners. And yet, here you are, and you may need to become a joiner. You may need to join a group to do your hobby. So you want to be able to let go of that self-concept or that prejudice against being that way. Now, in apathy, in terms of self-management, apathy, self-management is an interesting exercise for me to do this because apathy, obviously, there's difficulty in self-management, and often it's something that the partner observes and is very frustrated with. But there are some self-management strategies that can be fruitful. Some of these I got from the mentalhealth.org.uk website, as listed below. So to break tasks into manageable chunks. So you heard me say about the executive dysfunction planning. So don't look at it as a whole. Look at it as a step-by-step, manageable chunks, even writing them out. Write down each positive thing you experience throughout the day. Give yourself credit, even for the small things you do. So again, keep a journal. I did 5,000 steps today. Tomorrow, maybe 4,200. Write all of these things down. It's very motivational to have it a record. Be gentle and kind to yourself. Don't get down on yourself. Again, the more down you get, the more into that depressed way of thinking you will get, the less likely you're going to do things. Try to be mindful. Beautiful sunrise today. Try and be present with it. Attend helpful events. things like this, in which you learn about apathy and ways of combating it. Buddy up for activities. It's always better to do something with someone else, and it's more likely that you will do it. If you just walk alone every day, you will do it less likely than if you were to meet your neighbor to walk with. This is where a trainer can really help. You're paying for a trainer. Once you hand over the money, it's more likely that you will actually do some exercise. Join groups. Ask for help when you need it. Partner strategies. Praise. Avoid being overly critical. This can be really hard, like in that transcript that I read through for you about apathy. Day in, day out, it's hard. But really what you want to do is actually, as a partner, if you were the partner of the person in the transcript, what you want to do is go through whatever it is that you are asking the individual with Parkinson's disease to do, as opposed to being critical that they don't do it. Try and encourage them. Do it together, because again, the initiation of something new is problematic for some people. Sequencing what it is. They don't want to screw up. This is how you facilitate it. So you also want to facilitate self-management strategies. There are also medication management strategies. So the reward deficiency syndrome, where there's just not enough dopamine to get that positive kick out of doing something, dopamine agonists can be quite helpful with this. Methylphenidate is a stimulant. The other name for it that you may be more familiar to you is Ritalin. And bupropion is a kind of antidepressant that is also stimulating. Depression should be treated. A standard antidepressant is often sufficient. The thing to remember is the lowest dose. Bupropion, as I've said, is also a form of antidepressant that can be useful. For executive dysfunction, there's a group of medications called acetylcholinesterase inhibitors. These are medications that increase the neurotransmitter acetylcholine in the brain. And they actually have some of the best evidence for the treatment of apathy in terms of scientific studies, although dopamine agonists and methylphenidate are very frequently used. For the other activation deficits, dopamine agonists are also useful. So you see, with apathy, there is a number of strategies that can be used. There are some behavioral strategies for the individual, for the partner, but there's also things to talk about with a physician that you're seeing for the treatment of Parkinson's disease. However, with the medications, there is a risk. And I am going to switch tacks a little bit and talk about impulsivity. So we talked about apathy, which is low motivation. Now we'll talk about impulsivity, which is relatively high motivation. Especially what we're going to talk about is impulse control disorders, as well as punding and hobbyism. Now, impulse control disorders in Parkinson's disease are seen as being fairly stereotyped, which means that they are very specific. There are not the usual impulsive difficulties that can happen outside of Parkinson's disease. So the typical impulsivity can be substances, for instance. We don't often see that with people with Parkinson's disease. What we do see is pathological gambling. So excessive gambling that people gamble money they don't have, they borrow money, and often it is a marked change. It may be that you used to buy a lottery ticket once a week, now you're buying 10 a week, and using money that you don't have. You run out of money for rent, or you end up having to sell a home, which unfortunately has happened to too many people with Parkinson's disease that I have seen. There have even been some class action suits, both in Ontario and in New York State, because of that. Some people develop hypersexuality, and this is often seen by the partner. All of a sudden, the individual with Parkinson's becomes much more interested in sexual intimacy, watching more pornography. Even escort services are involved. People can become compulsive eaters, especially of sweets. Instead of eating a regular dessert, it's 20 cookies at a sitting. The cake seems to last 1 or 2 days. Some people develop compulsive shopping, always jail sites, buying stuff boxes seem to arrive out of nowhere, and they don't even seem to be getting opened. There's something about just the purchasing. And again, the purchasing can be very stereotyped to specific items. They may be cameras, they may be computers, hats, shoes. This is something that we see with people who are on some of these dopaminergic medications for the Parkinson's disease. Again, it's sort of, when you think of those loops, these individuals are often not responding to negative consequences as well as they should. Hobbyism and punding are excessive focus on one activity to the exclusion of others and not meeting responsibilities. Somebody is rearranging their clothes over and over and over again, and they're missing dinner, which they would not normally do. They're missing birthday parties because they have to keep rearranging those clothes, are examples. It can be as simple as that, or it can be more complex behaviors such as building fences. Like to build a fence, building a fence around one property, calling up a friend. Do you need a fence? Going over to the friend's house, building a fence. And going, and however many friends need fences, this is where the person goes. Or fixing motors is another one. So again, what happens in those situations is that with the appropriate treatment of the movement, the motor part of Parkinson's disease, the emotional motivation part of the brain that also responds to dopamine is relatively over-treated. This is what we saw in a study that we did way back in 2006. We saw that any agonist, any dopamine agonist, increases the likelihood that this will happen. The other thing that we saw is that the younger the person with Parkinson's disease, the more likely this will happen. So people who are in their 30s, 40s, and 50s were at a higher risk than those in their 60s and 70s with dopamine agonists and the risk of developing these impulse control disorders. The management of impulse control disorders, be aware and stay informed. So if you are starting a dopamine agonist, or if you are on a dopamine agonist, make sure that somebody knows, and have someone else check the finances, for instance. Check the credit card statements, just to make sure, because you may become more impulsive, and it may not have any significance to you, because for you, those negative consequences, those huge credit card bills may not really be all that important. And yet, if somebody else who cares and loves you were to see it, they would be flabbergasted. Have other people be involved. The other thing that needs to often happen is a decrease in the dopamine agonist amount. There is no safe amount. Even the smallest amount can sometimes cause problems. So sometimes the dopamine agonist has to be stopped. By decreasing, often decreases the activity. Self-help groups such as Gambling Anonymous can be helpful. Harm reduction measures, limiting access to finances and even blocking credit through organizations such as Equifax may sometimes be necessary. There are certainly families that I've come across who this is what they did. They wanted to maintain the dopamine agonist because it does create this motivation where apathy can be a problem. And yet, to limit any risk, they limited access to credit cards, to plastic, or even obtaining any other credit. And then deep brain stimulation surgery may be an option to decrease medications. It's important to note that it takes time. It takes time for some of these behaviors to extinguish, even once the dopamine agonist is stopped. Once the dopamine is reduced, the individual who has these difficulties will all of a sudden realize the gravity of the situation that they were not seeing previously. And this may lead to guilt and remorse. So it's a very difficult time, a time of adjustment and sort of consolidation of emotions, and need to build the relationship and recover in terms of an emotional sense. The other part that's important to note is that once a behavior starts, it's actually hard to extinguish. Once, let's say, eating a lot of cake or gambling has felt really good, even though that was fueled by a dopamine agonist and the dopamine agonist is stopped, the memory of how good it felt can keep individuals going back. Or even worse, what can happen is that if you have Parkinson's disease, you're no longer working. This is a way of trying to recover your losses, which is horrible because this is a gambling way of thinking and putting good money after bad money. So in conclusion, based on this presentation, I hope you realize that motivation problems are frequent, but one of many neuropsychiatric difficulties in Parkinson's disease. Apathy is common, and it has various ways of managing strategies, including those that are driven by the self, can be facilitated by the partner, or changes in medications through your physician. And that some of these medications can also carry the risk of impulsivity, so almost excessive motivation, especially where dopamine agonists are involved. And at this point, I would like to thank you for your attention, and I will turn it over to Steve.
Thank you, Dr. Zurowski. That was wonderful. And quickly, for those of you that don't know me, my name is Carrie Norquay. I work as a community engagement coordinator with Parkinson Canada, and I'm a part of the programs team, and I'm delighted to be with you again this evening. And I would love to introduce our next guest. Stephen Eisman was diagnosed with Parkinson's disease 6.5 years ago at the age of 46. He went through all of the usual stages of grief and finally settled on a resolve to fight. Convinced that a cure is coming, Steve holds the view that it won't mean anything if fitness is not maintained. Eager to share his enthusiasm for cycling, Steve co-founded the Rigid Riders, an organization dedicated to getting reluctant cyclists back in the saddle. Steve likes to see the world on a bike and is impatiently awaiting his next opportunity to ride the back roads of some exotic locations.
Thank you so much.
We're so glad to have you tonight, and I'm just so thankful that you're willing to share your own experiences with apathy. And I know the last few weeks we've had some great conversations, and that's just been a highlight for me. And I thought we might start off, you shared a really special story about a sandwich.
Sandwiches.
I thought it might be a nice way to start the conversation. So I'm gonna hope you can share that with our audience.
Okay, sure. I'll start by saying, wow, that I saw a lot of myself in the presentation that Dr. Zurowski just gave. Maybe I'm not the person to call to fix fences, but a lot of the other things really resonated with me. When I look back over the last number of years, I realize that I have been feeling the effects of apathy for some time. It was definitely influencing my work, how I spent my time, how I took care of myself, and the progression seemed to be pretty slow. In fact, I can't say I really noticed an onset, at least until things got really bad. And I recognized that they were really bad when I essentially stopped eating. And it wasn't because I wasn't hungry. I was. It wasn't that there was a lack of food. There was plenty, or a lack of time or opportunity. And it wasn't that I didn't need the energy. I was still an active athlete, and needed to keep eating. But I just couldn't, for reasons unknown to me, muster the initiative to go and make myself a simple sandwich in the middle of the day. And here was my thought process. As I'm sitting in my chair, ensconced in some activity, I would think, boy, to make that sandwich, I have to get up. I have to walk around that thing that I always hate walking around. Go up to the kitchen, open the the refrigerator, get out the meat, go over someplace else, get out the bread. And a particular challenge for me was adding cheese to this sandwich that I'm conjuring in my head. I'd have to open the drawer, unwrap the cheese, cut it, rewrap it, put everything together. What I found myself doing was imagining. I felt a little hungry. I knew it was time to eat, and I would imagine all of these annoying steps that I had to take, and I just wouldn't do it. And an entire day would go by, and I hadn't eaten a thing. So by this point, I clearly knew there was something wrong. I didn't know what it was. My first thought was maybe I'm experiencing depression. It's not something that I was familiar with, so I really didn't know how to self-diagnose it, except to say that I didn't, despite what was going on, I didn't feel unhappy. In fact, I would say I actually felt pretty content. I thought, well, maybe my motor skills had decreased to the point where all these manipulating that it takes to make a sandwich was now too much of a problem. But I still am an active athlete, so that didn't seem to fit. And then I thought maybe I'm just too damn lazy to go upstairs. But my day was filled with activities, and that didn't seem to fit either. So I had a consultation with a psychiatrist with knowledge about Parkinson's disease. And when the concept of apathy was first explained, it's like a bell went off. I said, "Oh my goodness, that completely rings true with me."
And when Dr. Zurowski was mentioning about upwards of 40% of those living with Parkinson's experiencing some form of apathy, were you surprised by that number?
I assumed that this was even after I was aware of apathy. I'm participating in a number of groups, and we have a lot of frank conversations, and it's actually not something that comes up very frequently. And it, the way I would explain it to myself is that maybe people don't necessarily know that there's an association between Parkinson's and apathy. I certainly didn't. Maybe there's embarrassment that comes with it, and it's a topic that people are apt to avoid. I'm certainly not out of the woods. It's this is something I contend with, but I've given some thought to things that I think have been helpful for me as coping mechanisms. And the first was knowledge, knowing about this apathy and the implications of it really seemed to make a big difference. There was some tension and anxiety about why didn't I feel compelled to do something, but giving a name to it and knowing that I wasn't making this all up in my head, but this was an actual thing. I think that let me engage sort of the problem solving part of my brain. I got myself on the team, how I was gonna do something about it now. Also clearing roadblocks. So with the example that I gave of the sandwich, putting cheese on the sandwich was one thing that I always seem to seize on. So I now buy pre-sliced cheese. Problem solved. Looking for motivators. Everybody has has a sense of what motivates them. For me, I tend to be goal oriented. So I do two things. I now try to set specific goals for myself, and a trick that I'm now practicing is not to be private with those goals either. In fact, be very public with them, and the benefit of that is that there's some social accountability that goes with it. It just makes you more likely, just like Dr. Zurowski was saying, joining clubs and having buddies participate, really does make a substantial difference if you don't keep it all to yourself and in your own head.
That's great. I'm sure it was the lovely graphic behind Steve of the rigid riders. I know it's, I've been looking at it lots, and I know people are probably really quite curious to learn a bit more about that, Steve. And really, when you were sharing about your story and your experiences with apathy, how that sort of came into play when you were looking at being able to manage apathy in your life. So could you maybe just walk us through a bit about rigid riders and how that's helped you in your journey?
Absolutely. So this Rigid Riders initiative started when I recognized that people living with Parkinson's were really underrepresented in even in participating in charitable events to raise money for Parkinson's research, and it drove me crazy because there's this clear association between being athletic and the motor and non-motor benefits that you derive from that. So I was really an enthusiastic cyclist, and I get passionate about it, and I really wanted to extend that to others and help draw other people in. But as it happens, planning and organization and all those things were holding me back a little bit. So I had the good luck and good to pair up with a friend, Mike Logren, who is skillful in so many of those things, and together we ended up making a great nucleus of a team, and we're definitely wanted to draw others to the light. Come to the light. I have one other piece of advice to pass on, and it's so for people living with Parkinson's, when it comes to things like apathy, I went through maybe 5-10 years of changes and never really noticed it. But those around me certainly did. And my advice to people living with Parkinson's is pay attention to the comments and observations that others have. Don't dismiss them all out of hand. Don't be too prideful to listen to it. And if there are caregivers who are listening to this, if there's things that you notice, you must find, and if hopefully you can have a frank conversation with the person that you're sort of caring for, and there's acceptance. But if there's not, find a way to get that information to their doctor. In my experience, the doctors that are involved really love hearing from caregivers and others living in the house. It can be a real window into information that's important for them to hear, and it can really make a big difference.
I think that's such sound advice, especially knowing, I know in our audience today we have many living with Parkinson's, but I'm sure equally we have those that love someone with Parkinson's, and just how it's really a team approach. And I know when we talked, Steve, a bit about apathy, you were saying that it was almost hiding in your life, that it wasn't something that you easily recognized. Did you find your family, did they sort of start bringing stuff up with you, or was it more self-discovery yourself?
Well, so Dr. Zurowski had that quote about not just small interactions between a husband and wife.
Yeah.
That was out in houses all over this country and beyond, because I'm saying this not just because I suspect that my wife is in earshot, but because it's true. Boy, if 40% of people are going through this, what I have gone through and continue to go through, that's a lot of conversations that still need to occur. And you say hiding. So Dr. Zurowski was talking about sort of this. He showed this graph of this limbic system and the extremes that you can experience. The drug interactions that you're involved can cause you to think in a certain way or operate in a certain way, and that can confuse the picture of apathy, which may be part of what's going on in your background, but it's sort of hiding behind all of these other symptoms. So all the more reason why you have to bring it up in front of somebody who can see the puzzle pieces for you and put together a picture so you know what you're dealing with.
That's wonderful. So just some practical advice is, from what I'm hearing, is for those care partners listening and sort of having a list of things they're observing with their partner and taking that information to the next neurology visit or with another healthcare partner. So I think that's just a wonderful thing to share. I just appreciate your candor, Steve, on all of this. I know it's not always easy to talk about, and we sort of serendipitously came across this. I know that you had shared your experience with apathy, and we were having this webinar, and it just sort of worked out so well. But I just really commend you for being open to sharing this. I'm sure those listening probably saw themselves in your words at many times, and I just really, honestly, I'm so thankful that you were willing to come on and share. And just before we end the webinar, do you have any last sort of piece of advice or any words of encouragement for those listening this evening?
For me, words of encouragement. I'm still hoping for fence building skills to find me. it's now high on my list of things to obsess about.
That's lovely. I love that. That's wonderful. And I know we've had a lot of questions come in from our audience throughout the webinar. So Steve has also agreed to stay on after the webinar is done to answer some of those. So I just want to let the audience know we will be sending out a follow-up email from Parkinson Canada with, again, the attachment of Dr. Zurowski and Steve answering your questions that you've submitted. And we've had some questions about the rigid riders. So in that follow-up email, we'll be sending out some of our resources for apathy and impulsivity, and we'll include some great information on rigid riders as well. So please stay tuned for that. And again, I just want to thank both Dr. Zurowski and Steve Eisman for joining us this evening. We hope you've learned some great information and that you've been able to relate to some of the topics that we've shared. So again, thank you to everyone involved, and I wish everyone a lovely evening.
Thank you.
Thanks.